My name is Thomas Kohnen, University from Frankfurt. I'm the chairman there. My topic today is the study results from the ACUNEX VarioMax IOL, which we have studied over the last year, 1.5 years, 2 years. Financial disclosures on my slide. I consult for companies, also for Teleon, in regards to the IOL. If you look at the intraocular landscape, this is a very simplified picture which I put together with my team, talking about monofocal aspheric, monofocal plus multifocal, EDOF, and eventually accommodative IOLs. But I think you need to take a look at the ISO criteria. This whole thing, what I'm just showing now, nothing to do with the VarioMax, but is a very hot topic at this meeting. We just had a meeting, the ESCRS executive and the ASCRS executive, talking about this classification. And we're going to bring that to our colleagues to ASCRS, and we want a worldwide, let's say, collaboration or worldwide change in the system. So the main categories are monofocal lenses, are toric, and then we call it simultaneous vision range lenses, SVL. And there, under this, you have 3 categories. One is multifocal lenses. You all know emphasize optical and functionally useful acuity levels at far, but when compared to monofocal control lens, also have improved optical and clinical performance at intermediate. So, for example, trifocal lenses and near distance. Then we have the extended depth of focus EDOF lenses, emphasize optical and functionally useful acuity levels at far, but also from far through intermediate. So the focus is more on distance to intermediate. And then you have the so-called full range vision. Full visual range, emphasize optical and functionality, useful acuity level at far, but also from the intermediate to the near range. So this is the classification. And then finally, the fourth is accommodative IOL. That's the only thing the ISO criteria had. You cannot find anything on monofocal plus. Doesn't exist. It's just not there. So this is the group, the working group of the ESCRS. You can see all the figureheads here. This is a publication, just came out at the August issue of JCRS, Journal of Cataract and Refractive Surgery. And what we have done is we looked at simultaneous vision IOLs, and we ranged them into partially range of vision and full range of vision. And that, for us, seems to be a much better explanation to patients and also in the future to categorize companies. Why? Because we can say this lens has a full range or it has partial range, but it's still presbyopia correcting because intermediate is not normal, it's not just distance. So you can categorize them, and then you can go further and say in the partial range you have narrow, enhanced, extended, depending on the defocus curve. And then also in the full range vision, you have continuous smooth transition and steep transition. So the clarification is shown here. And if you take the defocus curve of these lenses, various lenses, it's not a specific lens, you have all this. I'm doing this at the beginning of the talk because at the end I will try to find a way for the lens. So lots of multifocal lenses are available. Multifocal lenses provide good visual acuity at far, intermediate, and distance. You all know that multifocal lenses have a downside, and that is optical phenomena. We know this from the patients. And we have, of course, different designs. And the VarioMax has a refractive design, which I show in the next slide. What is the difference? If you have a diffractive design, you have light transmission and you have a loss of light. So usually the lenses are between 80 to 85% light transmission. If you have a refractive design, then you have more light coming through. And that design is shown here with distance and near of this lens. And here you can see the ACUNEX VarioMax. The lens was studied from us with the visual acuity at different distances, range of vision. We looked at patient satisfaction, spectacle independence, visual quality, and also refractive outcome. The study was done currently still an interim analysis because we're finalizing the data in the next week. So we are done with the study, but we have to work through the IRBs and everything to put the paper together, basically we look at the 3 months follow-up at the moment. This will be the paper with uncorrected, best corrected visual acuity, intermediate, near visual acuity, all uncorrected and best corrected. Usually the best corrected is better because you titrate a little bit the refractive errors, spectacle independence, patient satisfaction, visual disturbances, and also the defocus curve from -5 to +2 is a normal defocus curve in half a diopter steps. In this study, we had inclusion criteria, bilateral cataracts, age older than 30. Important is that we wanted to achieve the astigmatism because we didn't use a toric lens version, just a normal lens. So the patient had in pentacam 4 millimeter total corneal refractive power, less than 0.7 diopters astigmatism, and we tried to reduce it even, but we wanted astigmatism below half a diopter. Pupil size at least 3, but not larger than 6. The center shift of in pentacam less than 1 millimeter, and of course assigned informed consent, and exclusion criteria, amblyopia, irregular astigmatism, previous ocular surgery of any kind, and then in particular corneal refractive surgery, because we all know this is a difficult thing. So we excluded these patients. Here are the results, monocular subjective refraction. You can see preoperative we had quite emmetropic patients, but even postoperative, 3 months almost emmetropia. So we were already good with the A constant with this lens. Sphere, we changed from 0.26 to 0.15. Cylinder, you can see what we did, half a diopter, we went down to 0.2 diopter. So we reduced astigmatism in these patients. I was a surgeon of all these patients. 2 of the 15 patients needed spectacles in some visual tasks 3 months postoperatively, in some. So here is the uncorrected visual acuity again at 40, 60, 80 and 40 centimeters, 4 meters, 80 centimeters and 40 centimeters. And you can see very close to logMAR 0, which is 2020 or 1,0 in the German language. Little bit less at the 40 centimeter, but if you do a little bit the best corrected and binocular situation, you see that it's even improving. This was the uncorrected, this is the corrected, a little bit better because we took out these tiny refractive errors. Here's the cumulative uncorrected and distance corrected visual acuity for distance. So you see here the range at this point of 0, which is 20/20 or 100 or 1,0. 10 is very good, 94%, 66%. That's for distance. If you look at 80 centimeters intermediate, you go up to the range of 0.2 in logMAR. So also very good, 20/25 in that range, very functional at 80 centimeters. And if you look at 40 centimeters, which is, you can call it intermediate or you call it near, but it's in the range here, reading distance. Still, we had the vast majority of logMAR 0.3 and then 50% 0.2. This is the defocus curve. Defocus curve with standard deviation. You see the standard deviation is quite nice. So like a normal defocus curve in a human being, you always have a intermediate dip, and then it goes down for the distance, near visual acuity at the end of the curve on the right side. So that's a nice one. And photopic and mesopic contrast sensitivity was compared to what we saw in the literature to our own results, very good, as you can see this here. Now I'm looking a little bit at the optical phenomena. No lens, even a monofocal lens, doesn't have any optical phenomena. We found none in 30%, and then the questionnaire goes in this direction. And of course, if you ask patient for any of these, they will say yes. If you don't ask them, just, can you tell me what you have? Then they even don't know how to explain it sometimes. So we go specifically them, and my experience is then the numbers are a little bit higher. But you know, that's the outcome, and you can see yourself, halos 50%. You can go further, optical quality, different light conditions. This goes for low light. It goes to blurred image, blurred vision, starburst, halo, glare on this side. And then under bright light conditions and dark light conditions, you can see at the red, in the lower part here. So depending on the pupil size, you might have a little bit optical disturbances or more optical disturbances, which is normal. So let me conclude this non-toric version. We have not done the toric version. Demonstrated for us visual performance of the ACUNEX VarioMax, very good results at distance and intermediate and near. We have a high patient satisfaction. Patients were very happy, good visual acuity and under different light conditions. High spectacle independence, so 86% with good contrast sensitivity at 3 months. It's pretty good in our examined patients. And let me come back to the nomenclature. This is actually not the paper, but this is my editorial, which I added in the Journal of Cataract Refractive Surgery, and I called it current, which is what we had now, and future nomenclature of categorization of intraocular lenses. And it explains a little bit what you see in the paper. So if you're really interested in the paper, read also the editorial, because it's a one-pager, and I try to summarize everything. This is a paper again. Let's look at the categories. And I think from what I found out in our study, we would place this lens, the VarioMax lens, at the full range vision, because that's what the lens does. You can argue a little bit with near visual acuity. You have to be careful because there might be some patients occasionally needing reading glasses, but that's not the worst if you have 86% having no glasses at all. So with all respect to all patients, I'm putting any of these presbyopia correcting IOLs in, not only Teleon company, but also others. I always tell the patients you may need glasses at specific distances. Sometimes some have intermediate. They cannot see the computer superb. Or if they have a +1 lens, they might even be happier. But they don't use it every time, occasionally. So we place it here, and I think that goes aligned with this chart here. These are the defocus curve. If you take your defocus curve, it's up in the left side. So it's a continuous range of field vision, which we found in our study. That's the first time actually I did this, to categorize after I have done a study, the lens into this format. And I think that's a nice closure of that paper. So with this, I would like to thank you for your attention. We just finished in the study. We need a little bit of time to get the publication, so then you get this also in press. Thank you.